Good morning, everybody. Welcome to Grand Rounds for those of you that are physically present here and those online. And to the people online, could I ask you to mute your programs so that it doesn't come through to the auditorium? The land acknowledgement, as is usual, we're grateful to the Musqueam, the Squamish, and Tsleil-Waututh people to be working and living on these lands. Today's topic is scleroderma. Dr. Kim is a rheumatologist who specializes in scleroderma as part of her practice, did some of her training in Montreal to get skills in this area. And just so you know, it's probably the area of rheumatology that's, I think, personally most difficult for a variety of reasons. So I'm very interested to hear Dr. Kim's approach to this very difficult area. Dr. Kim.
Okay, thank you for the kind introduction and having me today for a presentation. I'm hoping that it brings up some of the questions and comments and discussions, because some of the points isn't sort of solely about the management per se, but I'm going to highlight some of the limitations and some of the new stuff that's coming up. So today we're going to be talking about scleroderma limitations and advances. These are my disclosures and objectives. So I'm hoping that today I can touch on heterogeneity in presentation of patients with scleroderma and some of the limitations that we still face in terms of evaluation, diagnosis, and management of these patients, and some of the new technologies and advances that we are hopefully will see soon. And then lastly, I want to emphasize the importance of a collaboration in managing our patients with systemic sclerosis. So as you may know, it's a rare disorder, but high unmet need. So the peak age is typically 30 to 50 based on the literature, although we do still see patients outside of this age range. There is female predominance with about 3 to 5 to 1 ratio. In terms of prevalence, it's about 276 cases per million in US. So assuming a population about 328 million in US, expected about 6,000 cases per year of diagnosis. The exact prevalence of scleroderma in Canada is a little bit unknown, and I think estimation ranges too much for me to be able to say, 70 to 400 cases per million. That's quite a wide range. So I probably stick to the US data for that. It's quite heterogeneous disease, as you may have encountered. It's multi-organ involvement. So you may have encountered these patients in lung clinic when they have ILDs or pulmonary hypertension. There's sometimes a renal involvement. Most well known is scleroderma renal crisis. It's not common, but when it happens, it can be quite lethal. And then GI involvement is very common, estimated to be up to about 90% of patients, and it can be anywhere from mouth all the way to the anal sphincter, essentially, with a variety of different manifestations. It doesn't necessarily lead to high mortality, but it is one of the symptoms that is most difficult to treat in our patients. Vascular involvement, again, quite common. Up to about 95% of patients will have Raynaud, and up to about 50% of patients will have digital ulcers. Again, this often doesn't lead to mortality, but again, leads to significant morbidity and disability and functional difficulties for our patients. Lastly, psychosocial impairment is quite significant as well. Up to, studies say 65% of our patients face anxiety and depressions. And as you may have heard, it can be severe and life-threatening disease. It's one of the rheumatic conditions with still the highest mortality. Average survival is about 11 years from the diagnosis, which is quite poor thinking, in this day and age. And in addition to that, not just mortality, but disability and morbidity is still very high as well. The second line here, economic burden study, this was a Canadian study based in Toronto, and economic burden is estimated to be about 1.9 billion in Canada. And 56% of the Canadian patients with scleroderma are work disabled. So more than half of patients are disabled, essentially. This is a quick summary of a subset system of systemic sclerosis that is most widely used at this point. So it's based on the skin involvement typically. So limited cutaneous scleroderma and diffuse cutaneous scleroderma. And it's essentially based on the skin involvement. So if you have a skin involvement up to the elbows and up to the knees and distally, that is limited subtype. Face can be involved in and limited as well. But if you have anything involving sort of a proximal to the elbows and proximal to the knees in your upper arms or upper thighs or trunks or chest, that becomes a diffuse cutaneous subset. Rarely there is some small portion of patient who has no skin involvement whatsoever, but internal organ involvement. And those we call systemic sclerosis sign scleroderma. So no skin involvement, but diagnosis of scleroderma. And more we're recognizing more of an overlap syndrome in our patients as well with other connective tissue diseases or sometimes other autoimmune disorder like thyroid disease or primary biliary cirrhosis. 10 to 20% of scleroderma can have PBC actually. So I do sometimes check their liver enzyme, full panel of liver enzymes. And if there are elevated, like ALP and GTT are elevated, I would go on to do some more additional autoimmune liver disease antibody panels as well. These are some of the scleroderma specific antibodies that are widely known. So centromere and topoisomerase 1, which is SCL70, and then RNA pol 3 are the three that are included in 2013 EULAR ACR classification criteria. There are some more new ones that have been found that are not quite added yet, and I'm sure there's more that's being investigated as well. So the centromere, I think everyone knows, or not many people know, it's included in our ENA panel. It's often more associated with limited. I would say most of the times it's associated with limited cutaneous subset. Topoisomerase is more associated with diffuse subset. RNA pol 3 is not included in our ENA panel, and so this needs to be ordered to the mitogen in Calgary. I often order this, especially if they're ANA positive but negative centromere or topoisomerase, then I would consider a mitogen panel for RNA pol 3. It is more often associated with diffuse subtype. It is also associated with renal crisis and rapid progressive skin disease and malignancy. So in someone with RNA pol 3, I would be a little bit more, I would do more close follow-up upfront and also do malignancy screening and also monitor their blood pressure closely for any renal crisis. So today I'm going to go through hopefully this case, and if there's a time I could add on another case, but I'm hoping to take this case of Ms. D to show, illustrate some of the learning points about the limitation and advances. It's a pretty typical case of scleroderma that we see, not anything unusual. So she's a 58-year-old female, previously completely healthy and active. She was followed by a rheumatologist since 2015 for a question of CTD based on ANA positivity and SSA positivity and possibly chilblain in toes. And April 2021, she re-presented to the rheumatologist because of a new onset hand joint stiffness and pain. The question of inflammatory arthritis was raised, but MRI hand showed no evidence of synovitis. A month after and at that time, the rheumatologist did a repeat serology, which again was same as before, ANA and SSA, but negative other things. And then a few months after that year, she developed new onset Raynaud, and then severe acid reflux, and then slight puffiness in the fingers that was noted on examination. So at that time, she was diagnosed with scleroderma. Repeat serology, again, didn't seem to show much different, same ANA and SSA. And then she was sent for a Mary Paffer for their assessment. Just for non-rheumatologists in the room, I just want to touch on the evaluation of a skin sclerosis a little bit. So currently, the gold standard is modified Rodnan skin score, which is done on the 17 body parts with the 0 to 3 being a scoring system, so total of 51. Talk a little bit more about that. So it was first described in 1982, and so it's a sort of old method that we still use at this point. So 17 body parts, 0 to 3, 0 being the normal skin and 3 being the most severe. As you can imagine, there's quite a significant inter-examiner variability, about 4.6 score, and then intra-examiner variability of 2.5 still. The clinically meaningful change of Rodnan skin score is typically felt to be about 5. And so you can see how the inter-observer variability can get in the way of that in the assessment. So how you examine it typically is to trying to pinch the skin with your fingers between your first and second and try to roll to see, feel the true thickness of the skin. So if you can lift up the skin and make a fine wrinkles, or if you can pinch it and make a fine wrinkle between in the skin, that's essentially normal skin, and that would be score 0. If you can still make a skin fold, but still like unable to make that fine wrinkles, then it becomes it's a score of 1. If there is a significant sort of difficulty making a fold and it's thick, then it's 2, and then most severe, it's an inability to make skin folds between the two. So that's when you're really hardened and fibrosed in all of the skin. Having said that, in someone who's had disease for long duration, you can get atrophy after many years, on average about 7 years after the diagnosis. And so when you have a skin, initially inflammation and puffiness, and then the thickness, which is a fibrotic stage, and later on it becomes atrophied. And so the skin itself actually can get thinner over time and can become normalized. If you see patients with scleroderma or long disease duration of scleroderma, they can still have sclerodactyly, and there's a lot of skin tethering to the underlying tissue because of the fibrosis and the disease. And so sometimes it's hard to lift up the skin, but that's mainly because of the tethering, not necessarily because of the skin fibrosis or skin thickness. So back to the case. So she was diagnosed, I agreed with this diagnosis of systemic sclerosis. And at that time in November, her skin score was 11. So she had a quite significant tightness in her fingers bilaterally, and dorsum hand, she had 2, so moderate skin involvement in her back of the hand and mildly in her face. So she was started on mycophenolate, which is often the first line medication that we use for the skin sclerosis or sometimes for the lung disease. She had to stop it shortly after because of a liver, actually she had to stop it, yeah, that's right, a few months after because of a liver enzyme elevation. And the primary rheumatologist changed this to the methotrexate instead of MMF. But at that same time, he also noticed that there has been significant skin progression just within that 3 months period. And so he sent her back to our clinic for an urgent assessment again. It's not her picture, but I try to pick some of the pictures that kind of resembles her presentation. So a few months later, she presented with the modified Rodnan skin score of 9, now presenting up to the upper arm and into her chest. So when they have a chest involvement, you'll see some like sort of shininess in the chest, and sometimes you see hyperpigmentation changes. And in the arms, it becomes tighter, and you can see shininess and also sometimes a groove sign. So kind of the groove where the muscles and or veins go in. So I put this in. This is a copy. It's a small portion of my note. So at the top of my note, I typically do a summary of her disease, and I took this to show the limitation and the mistakes that I made that I learned from. So I put it here that she had a new diagnosis of limited scleroderma. initially she presented with limited diagnosis, but at the same time, within about 3 months, she has progressed to a diffuse subtype. So I stopped doing this unless I know that the patient had limited disease for 10 years, 20 years, right? Because it almost gives us a false sense of the security that this is a Crest syndrome. And Crest syndrome is really limited to no major organ. It's really sort of a mildish form of scleroderma. So in terms of a communication to our colleagues and even to myself in the future, looking at the note, I think it gives a bit of a false security. And so I stopped doing this, but I still do. What I would do at this point in my practice would be, I would say, new diagnosis of scleroderma in what year. And with some of the presentation, and I might note what her skin involvement is in terms of face and hands here, or modified Rodnan skin score, and then the serology, instead of giving a full sort of name, whether it's limited or diffuse. So as you can see from this presentation or this case, there is limitation with the current subset system that is being used most widely. Certainly, the scleroderma skin disease can evolve over time, and it can cross from the limited to diffuse subtype. And also the other difficulty with the current subset or limitation is that it doesn't predict internal organ involvement, or it doesn't give any sense of prognostic factor for the internal organ involvement. I think back in the days, I think we were under the impression that the maybe diffuse form has more internal organ involvement and certain antibodies are more associated with this and that, but I'm not really sure if that is true anymore. I think it is so heterogeneous that it's hard to, that is probably way oversimplification of the disease. So there is currently an international collaborative effort to try to develop a new scleroderma subset system or subset criteria with the aim that the new subset criteria should inform research and communication in clinical or research setting, and the management and also the prognosis. None of the subset system that's been proposed so far covers all of it. So it's still being developed. The other limitation, as you can see, is the assessment of the skin disease in scleroderma. So the current gold standard is modified Rodnan skin score. But as you have seen, there is a high, it's subjective to, or so it's very subjective, and there's a high inter-observer variability. And also, it also is unable to detect the pre-inflammatory or fibrotic stage. Patients will often report symptoms such as itchy skins, painful hands, or stiff hands well before the development of the puffy fingers or skin sclerosis that is observed by clinicians. So, and that was the case in Ms. D's case as well. And so, future direction, there is some research being done about non-invasive imaging studies for a more objective measurement. And then there's some research being done about use of biomarkers as an early indicator and a prognostic factor. Some studies with the skin gene expression studies have shown that scleroderma patients can have some distinct transcript profile with the fibrotic and inflammatory transcript genes. And some of the studies show that it does correlate, or it does follow in parallel with the disease course in some. However, there's quite a bit of heterogeneity in that gene expression studies, and there's still conflicting data. So I don't think we have any sort of set biomarkers that are ready to be used clinically at this point yet. In terms of the non-invasive imaging studies, the two main ones that are being studied very vigorously in the scleroderma world is high-frequency ultrasound and the shear wave elastography. So I took this from one of the studies that are being done. So high frequency ultrasound is, I guess, defined as at least 10 megahertz or more in terms of the frequency. And compared to the conventional ones, it's felt to have more better imaging clarity and actually measure the thickness of the different skin layers. So you can see here that there's the different skin layers that are marked here. And in this study, they measure the sort of between the dermis, I guess, layer between the two yellow arrows. And this is a healthy control, and this is the scleroderma. And so you can see the quite dramatic difference between the dermis layer thickness that is observed on ultrasound. The shear wave elastography is also being investigated to measure the tissue elasticity qualitatively and quantitatively. Both together can be a more objective, sensitive, and reproducible tool than the modified Rodnan skin score. And this is sort of the shear wave elastography, that picture that's shown in the picture or in the paper. So they measure, the circles are the areas where they measure the tissue stiffness essentially. And so this is a healthy control, and this is the scleroderma patient. Numbers are hard to see, but there's definitely higher numbers seen in these circles in the scleroderma patients compared to the healthy control. Higher score meaning the more dense tissue or more fibrous tissue. Again, we still need more standardization of the imaging acquisition as well as the analysis protocol. So it's not quite ready to be used clinically, but those are being investigated for to be used as a sort of a next skin assessment tool in scleroderma patients. The other interesting thing, I guess, good thing about these imaging modality, in this same study, they looked at the sites that were not actually involved on the clinician. So they did the 17 areas of the modified Rodnan skin score, not only the areas with the skin sclerosis, but the areas that are not involved. And even though the modified Rodnan skin score was 0, based on the ultrasound, the shear wave, they could actually see some changes. So again, it may be more sensitive than our current measurement. So back to the case. So when she came back for reassessment, we did note that there's been significant progression from the limited type to the diffuse subtype into her upper arms. And so given the rapid progression, we started the pre-autologous stem cell transplant workup, including all of this imaging, and we've sent an urgent referral to the stem cell transplant. And essentially, in terms of a workup, she had very mild early ILD with a DLCO of 82, but otherwise no cardiac involvement, such as pulmonary hypertension or the cardiac myopathy. EGD showed gastritis with no GAVE, and so she was sent for a stem cell transplant. Stem cell transplant is one of the newer therapy, and I wouldn't say it's very new. It's still, the first study was done in 2014, so it's been out there for about a decade now. But at the same time, I think it's one of the treatment option that we have in scleroderma with most benefits shown so far amongst all the treatment options with most robust data. So I wanted to touch on this a little bit. So this is the ASTIS trial that was first published in 2014. It was a phase 3 RCT with 156 patients. So, other field, 156 may not be a large number, but in scleroderma, that's actually a fairly large number, especially in the RCT setting. And so if you look at the result, in the first year after the stem cell transplant, there was actually a higher mortality associated with the stem cell transplant. But after that first year of a survival over long term, there was significant mortality benefit in this population. And then the next one was Scott trial that was published in 2018, again an RCT. In this study, they've actually narrowed down the inclusion criteria, and they excluded anyone who had cardiac involvement to begin with. The other study actually included those. And the thought was that with the cyclophosphamide and the pre-transplant conditioning, there's high doses of cyclophosphamide, and they're subject to higher cardiac toxicity. And with that, they actually reduced the transplant-related mortality from 10% in the ASTIS trial to 3% in Scott trial. And then again, showing the overall benefit compared to the cyclophosphamide group. And so based on, just quickly about the process of a stem cell transplant. So as you can see here, initially, so the phase 1, they get evaluated and eligibility criteria and exclusion criteria, and they get mobilization with the cyclophosphamide and GCSF. And so they get progenitor CD34 cells into the peripheral blood, which gets harvested by apheresis and cryopreserved. About 2 weeks after phase 2 starts, with a conditioning regimen, usually involving cyclophosphamide and ATG, and then the progenitor CD34 cell gets thawed and infused via IV into the patient. And then the hematological immunological recovery happens after usually about a week or so, typically. And then they get monitored afterward closely for a couple of weeks in the transplant site. And then thereafter, it's usually about 6 to a year follow-up thereafter. So what happens in Canada? So in Canada, stem cell transplant for scleroderma indication happens 2 sites, one in Calgary and one in Ottawa. I think there might be one site in Manitoba, but much smaller. So major sites are Calgary and Ottawa. They typically include patients with early diffuse scleroderma, usually less than 4 years from their non-Raynaud symptom, but typically they recommend much earlier. So my usual goal is to try to refer within about 6 months if I see the progression of the skin, or even at least a year from the diagnosis if they have up diffuse skin or progression from in their skin sources, which is not always easy, but that's the aim. If they have general exclusion criteria is that if they have significant ILD, they get excluded. If they have any involvement of cardiac issues, so pulmonary hypertension or myopathy, they get excluded due to the cardiac toxicity concern, or any other significant organ involvement such as scleroderma renal crisis or renal disease, or their nutritional status if their nutritional status is poor. In Canada, in Western Canada, typically I will see the patient and screen them for eligibility criteria based on sort of their summary and some of the pre-transplant workup. When I refer, they'll typically do a consultation virtually first. The Calgary bone marrow transplant team will do a virtual consultation first while we try to finish up some of the workup. And then when they go to Calgary for stem cell transplant, they're usually expected to stay about 3 to 4 months in Calgary with the whole process. And then afterward, they get long-term follow-up with the Calgary bone marrow transplant team, 6 months, and then yearly thereafter, while they're followed by the rheumatologist here in Vancouver as well. I just put it in just to kind of show some of the collaborative work we need to get these patients ready for a pre-transplant, to get them ready for the transplant. And I do appreciate a lot for all the colleagues who helped me getting these done in a very urgent basis. So usually we want to screen them for any cardiopulmonary issues. So it's CT chest, PFT, VQ scan, echo, cardiac MRI, and right heart catheterization. And typically they would want it with exercise or fluid challenge. Apparently that is more sensitive in terms of picking up small chances of a pulmonary hypertension. So all of these, we want to get that done as soon as possible. So you can see how challenging that could be, but also very lucky to have the colleagues who help me out with those. GI evaluation, at least getting an EGD, I think is important to rule out GAVE. I've had a couple of patients who ended up going to Calgary and then had to delay their stem cell transplant because of a low degree bleed from the GAVE and getting an APC done multiple times while there. So to minimize, I don't think it's an exclusion criteria, but it's just to minimize any sort of length of duration, length of stay in Calgary. We try to get everything done here and do all the pre-work if necessary. And then sometimes there's some additional blood work and social worker or dietitian consult here. So most recent visit with Miss D, just to update you. So she had a stem cell transplant done in November 2022 with very successful result. So these are just the arrows that are broken here. So a modified Rodnan skin score pre-transplant was 21, and it went down to 14 6 months after post-transplant, and then 8 2 months post-transplant. And so it's continuing to improve. So it appears that there is an improvement sort of in the early phase, but the benefit lasts even into several years after, off of all immunosuppression. So I think that's really a great thing about stem cell transplant in some of these patients. Raynaud, interestingly, she used to have it several times a week, but it's that has improved dramatically. GERD has improved as well. The ILD is stable. So the Raynaud and GERD, we don't always see improvement in these things with stem cell transplant, but she has found that has improved. Hand function is improving post-transplantation as well. So she's been very successful. So just in terms of outcomes of the autologous stem cell transplant for scleroderma in BC, this is the most recent stat from the bone marrow transplant team from Calgary. So in total, they have done 46 cases of transplant for scleroderma in Calgary since 2011. So in the last sort of 10 to 15 years. And 14 of these are from BC. I suspect more, I guess, majority of them are from in the last 5 years or so, because prior to that, we've probably done less so. Unfortunately, 3 patients died due to the transplant toxicity, so almost immediately after the transplant. And unfortunately, all of those 3 are from BC. And we, after some discussion, we think that it probably or possibly is due to BC patients being referred in more at a more advanced disease state. So again, the emphasis is on early assessment and early referral if possible, but that's sometimes hard to do. There were 16 relapses over the median follow-up of 3 years. So even though there is some thought that it's sort of setting your immune system again, and there's sort of you got a new immune system, you're free of a new immune disease, it doesn't seem to be the true, at least in the 1/3 of the patients who have the relapse after. The relapse can be different things. It can be skin, it can be arthritis, a variety of different things. So that can still happen. And I think it's important to have regular follow-up thereafter, even after stem cell. 4 of these patients with a relapse died, unfortunately. So that was my first part. And then the second part, I wanted to also bring your attention to the overall scleroderma body's, or I guess group's emphasis on early diagnosis and early recognition of these patients. So there has been a term, the emerging term is VEDOSS, so very early diagnosis of systemic sclerosis, and the criteria was actually set in 2021. Very simple criteria. You got to have a Raynaud, and then number 2 is one of the following. So either ANA positivity, or if you have one of the scleroderma specific antibodies, or you have nail fold abnormalities, or you have puffy fingers. The rest of it, I think we're all quite familiar about, but this is sort of relatively new, at least in North America. I think it's relatively new. In European countries, they've been doing it much longer. So we'll talk a little bit about that. So nail fold capillary is essentially small, tiny blood vessels along the nail bed, essentially. Apparently, blood vessels in our body are perpendicular to the surface of the skin or our body, except at the nail bed where the blood vessels are parallel to the skin surface, so that you can actually appreciate and observe or see the whole morphology of these blood vessels. So this is a picture of a normal blood vessel, and this is quite abnormal. And we'll talk. I have a better picture the next slide. So this is a normal capillaries, nail fold capillaries, where you're seeing rows of hairpin-like capillary loops, nice and thin, and the density is preserved, meaning you see lots of them beside each other in a regular fashion. Whereas this one here is what we call scleroderma pattern. So you can see the quite a bit of disorganization overall and reduced density as well. And there's lots of dilated and tortuous blood vessels. And some of these ones, we call it giant loops because they're quite tortuous and quite dilated. And these are hemorrhages that are happening as well. So how do we monitor for them? There are many tools to assess nail fold capillaries. This is the dermatoscope that we commonly use in rheumatology clinic or dermatology clinic. But even regular iPhone with a magnification you can use, or microscope, or sometimes even the ophthalmoscope or otoscope in the clinic setting, you can use it. Essentially, you just need a higher magnification to see the nail fold. And this is more advanced tool, which is the nail fold video capillaroscopy we now have at Mary Pack Arthritis Center. It's a non-invasive, all of these are non-invasive tool that's easy to evaluate the morphology of the microcirculation in the nail fold or nail bed. It's very useful to differentiate primary versus secondary Raynaud. And it's being researched for its role in sort of disease progression and prognostic factor. So that's what we have at our Mary Pack Arthritis Center. So that's the big machine there, and that's me there. And these are some of the scleroderma patterns. So the nail fold video capillaroscopy gives you about 200 times magnification, so much higher than the dermatoscope. And so you can see even the sort of which stage, early, active, or late stages of different nail fold patterns. And so you see the giant loops and some bushy capillaries as well. So I will touch on another case quickly. So this is a case of Miss H. So she's a 41-year-old female, previously healthy other than migraine and iron deficiency, but dental hygienist is really healthy. She had a new onset Raynaud 2016 after her third pregnancy, but pregnancy was fine. She felt fine. She didn't really seek any medical attention. 2019, she felt worsening Raynaud, and so she saw her family doctor. All the blood testings were done, and those were completely negative. And then she went on to, for a few more years, just kind of didn't think much of it. And then finally it was getting worse, and she saw a rheumatologist in 2022. Serology was repeated, but again, everything was negative essentially. But at a routine follow-up by her rheumatologist, the rheumatologist noted changes on the nail fold capillaries on dermatoscopy examination. So she was referred for video capillaroscopy. And this is the video cap examination. So I took a picture of the screen, so it's a bit fuzzy, but you can see that it's quite abnormal. So there's quite a bit disorganization. It's not a hairpin loops that are in a row. There's lots of hemorrhages, and there's a lot of these tree-like capillaries that are bushy capillaries. So based on this, I said, this looks quite abnormal. It could be early scleroderma or at least scleroderma-like pattern. But on clinical history and physical examination, she didn't have other symptoms. We've done the mitogen panel, and it actually came back positive for CNPB, which is essentially centromere pattern. So she now meets a VEDOSS criteria with the Raynaud, nail fold abnormality, and scleroderma-specific antibody. And then soon after, she's developed mild shortness of breath, NYD, but no other features. So she then went on to get more internal organ screening with the echo, PFT, and chest CT. PFT shows mild restricted pattern with the DLC of 77%. She's otherwise young, 41-year-old, very active and healthy person. So she was referred to the respirology, who felt she didn't have ILD because CT scan really didn't show any ILD evidence of it. She is being tried on PPI for possible GERD, whether that's a contributing factor, but she's also being referred to pulmonary hypertension, or she has been referred to pulmonary hypertension clinic and pending a right heart cath. So you can see in this scenario completely negative serology, but Raynaud, and with the nail fold capillary changes, we are potentially detecting internal organ involvement at a very early stage where the intervention can make significant difference in her mortality and morbidity. So benefit of VEDOSS, I think so. We can monitor and identify these patients at risk earlier on, and we may be at a window of opportunity for early intervention. And so I think there is huge benefit of these early detection of these patients at risk. Again, lastly, I think we all, I certainly, and some of our rheumatology colleagues all appreciate the collaborative management of our patients. So for these patients to be able to get diagnosed for internal organ involvement and to be followed for monitoring, we often work with other specialties very often, pulmonologists, kidney doctors, cardiologists, all of the internists together. We work on these patients. Again, targeted treatment, again, requires lots of collaboration. So we often use immunosuppression, but sometimes it's outside of immunosuppression. For example, pulmonary hypertension is all with the vasodilator, which is foreign to me. And so we certainly appreciate help from our colleagues in PH Clinic. And then ongoing research collaboration is also very helpful. So hopefully today, I hope I did uncover some of the limitations that we face in diagnosis and some of the criteria that we use and some of the tools that we use in managing our patients. We're hoping that there will be some new technologies and new tools that we can use to help earlier recognition of these patients at risk. And again, about